meeting to order.
Welcome, everyone, and thank you for joining us for this meeting of the California Technology Assessment Forum, CTAF, a core program of ICER. My name is LaWanda Grisette, and for this meeting, I will be serving as the acting chair as we discuss calcitonin and gene-related peptide inhibitors and their role in the treatment of migraine. At this point, I would like to begin by, as we do with every meeting, asking the members of the CTAF panel to introduce themselves, their roles, and I will start. I'm LaWanda Grisette. I am Director of Advanced Heart Failure and Cardiomyopathy at USC.
I'm Bob Collier. I'm with a group called Patient Advocacy Research that we started about 30 years ago, specifically to get patients integrated with the research process.
Dr. Gregory, before you go on, and I also like to ask for anyone, we have a process of disclosing any conflicts of interest before the meeting, but if there are any updates to the COIs that have been provided, please let us know about that. Bob, do you have any?
No.
Thank you.
It's going to be exciting meeting. Competing next door. I'm Kimberly Gregory. I'm Vice Chair of Women's Healthcare Quality and Performance Improvement in the Department of OBGYN at Cedars-Sinai Medical Center. And I have a joint appointment at the UCLA School of Public Health. And I have no updated conflicts.
I'm Joy Melnick-Hill. I'm a professor of family and community medicine at UC Davis and director of the Center for Healthcare Policy and Research there, and I have no conflicts of interest.
I'm Patricia Powers with the Center for Health Decisions within UC Davis's Policy and Research Center, and I have no conflicts of interest.
Good morning. My name is Jeffrey Hotch. I'm a professor of health economics at the University of California at Davis, and I'm the associate director of the Center for Healthcare Policy and Research. No updates on the conflict of interest.
I'm Michael Steinberg. I'm professor and chair of radiation oncology at UCLA and director of clinical affairs for UCLA Comprehensive Cancer Center. No conflicts.
Robert Rentschler, and I'm a retired medical oncologist. No conflicts.
I'm Bill Remack. I'm a retired medical technologist and chairman of the California Hepatitis C Task Force, located in Petaluma, California, and I have no conflict of interest.
I'm Alex Smith. I'm a physician researcher in geriatrics and palliative care at UCSF, and I have no conflicts.
Say Lee, physician researcher in geriatrics at UCSF.
Felicia Cohn. I'm the bioethics director for Kaiser Permanente Orange County and a clinical professor at the University of California, Irvine. No conflicts.
Jeff Klingman. I'm the chair of neurology at the Permanente Medical Group, and I have no conflicts.
Thank you, and I have no conflicts to disclose as well. Throughout the meeting, we will be asking all speakers to specify their conflicts of interest. Joining us today on the panel, we also have clinical experts and patients, and I would like for you also to introduce yourselves, starting from your left, your right, actually, and specify conflicts of interest and your role in the meeting, as well as what you do outside of here.
Good morning. My name is Jill DeLynn. I'm a registered nurse and I am a patient advocate. I work with the National Health Foundation and the Coalition for Headache and Migraine Patients, as well as the Alliance for Headache Disorders Advocacy.
Thank you.
I'm Kevin Lenneberg. I'm the executive director of CHAMP, the Coalition for Headache and Migraine Patients. Our funders include some pharmaceutical companies, for disclosure.
Hello, I'm Sonia Petrevic. I am the regional headache specialist for Southern California Permanente Medical Group, working here at Los Angeles, and I'm an expert reviewer.
Hi, Yvette Young, neurologist and clinical lead at Healthcare Partners Medical Group.
also a Kaiser and USC alumni for training. I have no conflicts of interest.
Thank you. This morning and throughout the meeting, there will be opportunities for question and answer, and I would ask that the panelists indicate whether or not you have a question by turning your label as so, and I will try to go in order. I have one more introduction to do, and at this time I would like to introduce Dr. Stephen Pearson, President of ICER, who will describe the background and mission of ICER and CTAF.
Thank you, Luanda, and thank you for being our chair today. Hi, everybody in the audience. Thanks for joining us, and those of you on the webinar. We're very pleased to have our patient experts and other stakeholders here with us today. There we go. So I'd like to start off with just a very brief introduction to why we are here today, what the goals of the meeting are, and a little bit about the background of the report and the deliberation structure that will be the focus for today's meeting. So why we're here today is that, again, we are faced with the pleasing prospect of real innovation that's going to promise substantial benefits to patients, their families, and the community. And I have a couple of quotes from those that we received during public comment. One here is about this, again, this brings up the issue about how serious migraine is for many individuals and for us as a society. This quote says, "You lose your sense of who you are, how to speak, how to think, how to move. You become a shell of your former self. The light hurts, that woman's perfume on the subway makes you sick, the sound of a baby's cry sends you into paralysis." That was one patient's comment. Another said, "I'm terrified of the day when I won't be able to work, as I have to spend so much money on medications and doctor appointments just to get out of bed that there's no way a Social Security disability income would support me, let alone my family." This gets at, again, at some of the concerns that patients have about how it's affecting not just them, but their families. And I'm just kind of curious, if anybody who has migraine headaches or a close relative who does, would you raise your hand? Keep your hand raised if you or that person has tried preventive therapy. Keep your hand raised if they've tried preventive therapy and it's really not worked well. I'm not surprised. I'm like many of you, and I know this isn't a random sample of Americans, but we all have some connection to people with migraine who are living with it, who've lived with it for a long time. And we know how serious it can affect people and how difficult it can be to try to juggle existing insurance structures, et cetera, to get treatment. And again, the opportunity to think about an innovative new treatment is part of why we're here today. The other reason is because often when there is innovation, especially with new mechanisms of action, it raises a lot of questions about what's the appropriate use of this in clinical practice? How much can we afford? For whom? How do we kind of put this all together? And one quote I brought is from an article that was reflecting on this, and it said an estimated 3.5 million patients have already tried a migraine preventive therapy here in the United States, and approximately 80% stopped that therapy within a year. And that's according to the calculations of one of the manufacturers. So 80% of 3.5 million is 2.8 million Americans. That's a lot of people who are trying preventive medication and are stopping them, probably because it's not working. So all of this also, concerns about access arise because patients can have difficulty accessing new drugs. The rules to get them can be very complicated. Sometimes it's hard for clinicians and patients to figure out what the rules of the road are. And so we've always thought that it really would help if we can have a public discussion based on an objective evaluation of the existing evidence and to try to pull together the threads of what we know today. We know that the evidence base is young because these drugs are just coming into practice. But what can we know today, since they are being asked for, they are being prescribed? What do we know today about their effectiveness, for which patients they offer the best promise? What can we know today about their long-term cost effectiveness and their potential budget impact? And how can we weave that together in a public discussion to help create a pathway to make sure that we get real, true, sustained access to high-value care for patients. So, as the forum for this, we are happy to convene the California Technology Assessment Forum. You've met their members today. I need to tell you a little bit about ICER, which is the group that creates the academic kind of product that is discussed here today. So ICER is an independent, not-for-profit group, and here's our complete funding stream. As you'll see, the big red chunk, 78%, is from nonprofit foundations, and that's the money that goes to these reports and meetings. And the chief foundations in that group are the Laura and John Arnold Foundation, the California Healthcare Foundation, and the Blue Shield of California Foundation. And we get roughly the same amount from healthcare manufacturers, drug makers, and biotech companies, and payers and PBMs, but that's for a separate policy summit program where we bring their leaders together to talk about evidence policy, and a small amount left over from government contracts. The report itself today, that many of you have looked at and that will be discussed in detail, started about 8 months ago. It starts with a scoping phase, and that's when we try to learn what we don't know by talking to patients and patient groups, to clinical experts, certainly to the manufacturers in this area, and other stakeholders as well. Now, we were lucky in this case because we had recently launched a new approach to being able to take information, confidential information from the drug manufacturers that could improve our understanding about the effectiveness and value of these drugs, but which elements of still need to remain confidential. So you'll see reference to some of this information throughout the day, but it has been submitted by manufacturers and it will ultimately be published, and there's a timeline for that so that we make sure that the evidence eventually, we always try to get it out as quickly as possible, but where necessary, we are willing to take this evidence in confidence as long as we can feel confident that it will be available to the public within at least 18 months. So, along with that, we do an internal review of the existing evidence by the ICER staff, and we often work with outstanding external cost-effectiveness experts. In this case, they were at the University of Illinois, Chicago, who led the cost-effectiveness modeling. Through several different phases of public comment and revision, we were also aided by expert report reviewers, including those 4 individuals that you see listed up there, one of whom is at the table already. None of them should be in any way considered responsible for anything in the report. They do not necessarily agree with it, but they gave us feedback, and we were very glad to get it in many different ways. So I'd like to kind of close by saying, how is the report itself structured to support a discussion around effectiveness and value? And to that, I just want to show a brief schematic. And it starts really, again, with this overarching goal. We hope that our work in this public discussion can lead to efforts to really achieve what we don't have yet in the United States, which is a health system that can guarantee sustainable access to high-value care for all patients. To get there, we think we need to think altogether about 2 things. One is the long-term value for money, and I'll say more about what's enclosed in that broad concept, as well as the short-term affordability, because the 2 can sometimes be in tension. For the long-term value for money, however, it begins with a clear-eyed look at the comparative clinical effectiveness of new treatments compared to what we can currently do. It includes the incremental cost effectiveness looked at over the very long term, in which we try to wrap up all the clinical and other benefits for patients, as well as the cost throughout the healthcare system, not just on drugs. And then we also want to talk about things that might slip through, that might exist outside the evidence even, but that could be considered potential other benefits of new treatments or different care options, as well as some contextual issues around the severity of the condition and other things that you'll see when we get to the votes. So when we do come to the voting, there will be explicit discussion about these elements as a set of factors that need to be considered in a vote on long-term, or judgment on long-term value for money. There's not going to be a vote on short-term affordability, but we will talk about potential budget impact. Again, sometimes, especially for conditions like migraine, where there are millions of affected patients, there's an issue about how we manage long-term value with the reality of what it's going to do to short-term budgets, and what that means and how we think about how insurers, manufacturers, doctors can help manage both. So with that as an introduction, just again a brief statement of how today's meeting will be run, the agenda. So we'll start following my opening with presentation of the evidence from Alexandra Ellis of the ICER staff and Suri Walton from the University of Illinois Chicago. Then there will be a phase for manufacturer comment and discussion with the CTAF panel. Then public comments and discussion, followed by lunch for the CTAF panel and the policy roundtable. Lunch will be just across the way. For the public, I'm sorry we couldn't make lunch available for everybody, but there will be, I'm sure there are options available. Oh, we are. You get a free lunch. There you go. Aren't you glad you came? In this case, there is such thing as a free lunch. We won't even take your email address and try to contact you later, I promise. So, following that refreshment, we will come back for the final phase of the deliberation and voting on clinical effectiveness and value, followed by a short break, and then the policy roundtable, where joining the patient experts and the clinical experts, we will have representatives from insurers and from the manufacturers, again, to wrestle with how we do this going forward. What do we take from our review of the evidence today? How do we plot a strategy forward? How do we create clinically sensitive coverage guidelines? How do we talk about pricing, cost, future research, the things that we need to think about going forward? We'll have final reflections from the policy roundtable and the CTAF, and promise to get you out by 4 o'clock. So thank you again for being here today. And with that, I will hand it back over to our chair, who can introduce the beginning of the evidence review presentation.
Thank you. So we would like to begin with Dr. Alexandra G. Ellis, who will begin the evidence presentation.
Thank you. I'd first like to acknowledge the contributions of my collaborators, Aoife and Catherine, and just note that we don't have any conflicts of interest for this report. So migraine is a debilitating and recurrent headache disorder, and it's also fairly common. It affects approximately 20% of women and 10% of men. Patients with migraine may experience moderate to severe headache pain, as well as other symptoms. Because the frequency and intensity and duration of these symptoms can vary between individuals and may fluctuate over time, the burden of migraine may be more severe for some patients than for others. So some patients may have a mild intermittent problem that can be treated with lifestyle changes or oral analgesics. Other patients, migraine can be severely debilitating. In addition, when patients experience migraines, if they're unable to obtain relief from their pain, they may seek care in an emergency setting. And of course, this is associated with substantial costs. Patients with migraine may be diagnosed as having chronic migraine. So this is for patients who experience 15 or more headache days per month, with migraine features present on at least 8 of those days. Patients with migraine who have not been classified as chronic migraine may be termed episodic migraine, but just note that this is not a clinical diagnosis. Among patients with migraine, approximately 10% have chronic migraine and 90% have episodic migraine. We heard extensively from individual patients how living with migraine can be very difficult and debilitating. So for example, some patients reported feeling frustrated when they were trying to communicate their pain and symptoms to others. Other patients felt depressed and even experienced suicidal thoughts. We also heard several comments from patients about how migraine can strain their relationships with family, friends, and coworkers. And this can be for a range of reasons. For example, some patients may not want to plan or commit to plans because of the uncertainty about when the next attack would occur. Other patients felt that their migraine pain was not taken seriously by others. Treatments for migraine first include some behavioral changes as well as some non-pharmacologic options. In addition, patients can take acute treatments. So these treatments would be taken at the onset of migraine symptoms, and that includes options including NSAIDs, triptans, and opioids, among others. Just a quick side note about opioids. Despite recommendations against using opioids as a first-line acute treatment, many patients with migraine are, in fact, prescribed opioids. So because of the concern with the opioid epidemic and its association, there is concern about this in the migraine population. In addition to acute treatments, some patients may be eligible to receive preventive therapies. So preventive therapies would be given for a short period of time or a longer period of time, and the goal would be to reduce the frequency or intensity of the migraines. Many preventive treatment options for migraine are available in a generic form and are taken orally. So that includes some options for within antidepressants, anti-seizure medications, as well as beta blockers. In addition, onabotulinum toxin A, or Botox, is indicated for the chronic migraine population. So there are no strict guidelines on who is eligible to receive preventive therapy, but in general, patients who have 4 or more headache days per month are considered candidates. And when a patient starts a preventive therapy, they're recommended to take it for a minimum of 2 to 6 months. And the reason for that is that there may be a delayed onset of efficacy. So it can take some time for patients to be able to find the treatment that works best for them. Patients also frequently discontinue or switch therapies due to lack of efficacy, but also and also because of tolerability concerns. So some common tolerability issues include difficulty with concentration, memory, or speaking clearly. Interventions have also associated with weight gain or loss. And we did hear from patients how frustrating and challenging it can be to find the right therapy for them. So these guess and test procedures can take many years before finding an effective treatment, and it's very frustrating to keep trying different things. When they do find that treatment that works, it may often stop working after a set period of time. And in addition, those side effects that I mentioned can be more debilitating or as debilitating as the migraine itself. So of course, there is a need for more effective and tolerable medications for migraine patients. There are many agents in development right now in a new class of therapies. So these are the calcin gene-related peptide, or CGRP inhibitors. And the CGRP pathway is important in pain modulation. The first of these CGRP inhibitors was approved by the FDA last May. And this is erenumab. And erenumab works by binding to the CGRP receptor. 2 additional therapies, fremonizumab and galcanezumab, work by blocking the CGRP molecule itself. And the FDA is expected to make a decision about these therapies by the end of this year. So here we've sought to take a look at the clinical evidence that's currently available on these therapies. Our scope of the review included adults with chronic or episodic migraine who were eligible for preventive treatments. And so we looked at chronic and episodic migraine separately. We also looked at the subgroup of patients for whom existing preventive therapies have failed. The interventions of interest were the 3 CGRP inhibitors, erenumab, fremonizumab, and galcanezumab. And note that these interventions are self-administered and typically with a 1-month frequency, although 1 dose of fremonizumab has been studied in a quarterly frequency. For comparators, we included 3 oral preventives, amitriptyline, propranolol, and topiramate. We also include Botox in the chronic migraine population. And for both populations, we included placebo or no active preventive therapy as a comparator. In terms of outcomes, we included all of those listed here. I just want to also draw your attention to our main outcome of interest, which was monthly migraine days. So for the evidence base in chronic migraine, we identified 3 trials of the CGRP inhibitors. So 1 trial in erenumab and 2 trials in fremonizumab, and no trials in galcanezumab. We also have 13 trials of Botox or topiramate, and of these trials, 11 were included in one or more of our efficacy analyses. We did not identify any trials of amitriptyline or propranolol that met our inclusion criteria. So here's a summary of the baseline characteristics of the patients included in the CGRP inhibitor trials. So as you can see, the average age across the trials was very similar, approximately 40 years old. And the average number of migraine days per month at baseline was also similar. Just note here that in the arenumab trial, patients were not allowed to continue using their preventive therapies, whereas patients in both of the fremanezumab trials could continue using preventive therapies. These trials had a 4-week baseline period, and they were a 12-week randomization phase. So here is an illustration of the available network of evidence that we had for the outcome of monthly migraine days. So here the nodes represent the individual treatments that we looked at, and they're color-coded, so green for the CGRP inhibitors, orange for Botox, and blue for the oral preventive therapies, and black for placebo. The presence of a line indicates a study has compared those two interventions head-to-head, and the thickness of the lines is proportionate to the number of studies. So we had 2 trials for Botox versus placebo, and for fremanezumab monthly dosing versus placebo, and 1 trial for the other connections. So we conducted a network meta-analysis, and the main results from the network meta-analysis for monthly migraine days are in the first column here. And so this is expressed in terms of a difference in the change from baseline of monthly migraine days for each intervention versus placebo. And so a negative value indicates a larger reduction with the active therapy compared with placebo. So across the CGRP inhibitors, we saw between about 1.3 and 2.4 fewer migraine days per month compared with placebo. And these results were not statistically significant compared to Botox or topiramate. In the second column, you'll see the results when we anchor with a placebo response of 4 fewer days per month. And this is just for illustrative purposes, but we want you to focus on the first column as the main results. I also just want to comment that we did have subgroup data available that was submitted in confidence for this outcome. So we're not presenting that data here, but it is available to the panel members in your packets. In terms of other efficacy outcomes, we were not able to do a quantitative synthesis of the proportion of people who had a 50% or more reduction in monthly migraine days, and that's because the way that the trials reported this outcome varied. So some trials used 50% response in terms of migraine days, others used it in terms of headache days or moderate to severe headache days. In terms of acute medication use, we saw approximately 2 fewer days using acute medications per month by the end of the trials. And quality of life measures were not frequently reported across the trials, but where they were reported, we saw larger improvements with the active therapies compared with placebo. But these may not be clinically meaningful differences between groups. For the evidence base for episodic migraine, in our reports and in our analyses, we've included 6 trials of CGRP inhibitors. However, in the past 2 weeks, there were 2 additional trials published on galcanezumab. So currently, they're not included in our report or our analyses, but I will make a couple of comments on them when we get to the results. We also have 24 trials of oral preventive therapies, and of these, about 16 were included in 1 or more of our efficacy analyses. Again, here is a summary of the baseline patient characteristics across the CGRP inhibitor trials. And just note that the last 2 trials, Evolve 1 and 2, are the 2 new galcanezumab trials. So these are not included in our analyses at this time, but just to note that they did have similar baseline characteristics as we saw with the other CGRP inhibitor trials. So overall, again, the average age at baseline was similar, about 40 years. And the average number of migraine days per month was also similar across the trials, with the exception of 1 trial in fremanezumab, which looked at high-frequency episodic migraine. So the baseline number of migraine days was a bit higher for this trial than the others. Again, note that Most of the trials did not allow patients to continue using their existing therapies, with the exception of the fremanezumab trials. So here is an analogous figure of the network of evidence for episodic migraine in terms of the outcome monthly migraine days. You'll note here that the CGRP inhibitor trials were all compared versus placebo, and we do have some head-to-head evidence between the oral preventive therapies. The results from the analyses, again, are expressed in terms of a difference in change from baseline for each intervention versus placebo. And as a reminder, a negative value indicates a larger reduction. Here we saw about 1.2 to almost 2 fewer monthly migraine days with the CGRP inhibitors compared with placebo. And these results, again, were not statistically significant versus the oral preventive therapies. I also want to comment that the subgroup data for the patients from whom existing therapies have failed is also provided in confidence and available to the panel members in your packets. In terms of other efficacy outcomes, we saw approximately a 2 times higher odds of having a 50% reduction in monthly migraine days with the CGRP inhibitors compared with placebo. So there may be some evidence to suggest that there is a subgroup of population that respond very well to these drugs. The results for acute medication use and quality of life measures were similar to what we saw in the chronic migraine population. In terms of tolerability and harms, overall, the CGRPs were well tolerated with infrequent and non-serious harms reported. So we did not find a difference in the meta-analyzed odds of discontinuations or serious adverse events. In the CGRP inhibitor trials, the most commonly reported adverse events related to injection site reactions or pain. In the oral preventive therapies, common adverse events included fatigue, memory loss, and difficulty concentrating, which were not frequently reported in the CGRP inhibitor trials. So in terms of controversies and uncertainties, first, that these trials were short-term, so between 12 and 24 weeks in duration. So there is some uncertainty in terms of the durability of any effects from prolonged use. And that includes durability of continuing to use the treatments and also any lingering effects that may occur once a patient stops taking the intervention. These are the first agents in the CGRP inhibitor class, so there is concerns about the longer-term effects of the continuous blocking of CGRP or its receptor. So CGRP is throughout the body and it has different functions. And so one concern is in particular because CGRP has a protective role during ischemic events. There may be a concern that patients who are at higher risk for cardiovascular events may not be well suited to take these interventions. There's also concern about the generalizability of these results. So the patients that might use these interventions in clinical practice may be those that have failed many interventions in the past or who have comorbidities. And these patients were not studied in the clinical trials. So just to summarize, we did see some clinical benefit with the CGRP inhibitors and few harms. But these trials were short-term, so we have limited certainty about the longer-term effects of these interventions. However, there are longer-term studies that are ongoing. Some of these trials did have open-label extensions. So we overall rated the evidence as insufficient for most comparators and populations. And the rationale for that was we did see clinical benefits, but these trials were short-term, and there's considerable uncertainty about the longer-term effects of these interventions. And this is particularly relevant because patients will be taking these drugs for a longer period of time, particularly patients with chronic migraine. The exception was that for patients who have more severe disease or who may not be able to take or who may not have other options available to them, we rated the evidence slightly higher. And that was because we thought that the benefits would perhaps outweigh the potential risks among these populations. So for episodic migraine for whom oral preventive therapies have failed, we rated the evidence as promising but inconclusive. And the same population in chronic migraine, we rated the evidence as comparable or better. In addition to the clinical evidence, there is other benefits and contextual considerations. Again, these are administered monthly or quarterly, which may reduce the burden of migraine treatments. But these are subcutaneous injections, so that may add some complexity to the treatment. If these interventions are both tolerable and effective, patients may be less likely to discontinue their treatment. And it may also have other effects in terms of an increased ability to work and improve overall productivity. Again, these are interventions that have a novel mechanism of action, and they may have an earlier onset than existing preventive therapies. So I'd just like to end on a couple of comments that we received from the public. The first was that the review should evaluate the CGRP inhibitors only in their likely treatment paradigm. So that would be among patients for whom preventive therapies have failed. And so during our scoping calls and conversation with patients and clinicians, we heard that there's an interest in the wider migraine population. So we took the approach of looking at both the wider migraine population as well as this subgroup for whom existing therapies have failed. Another comment was that phase 2 and phase 3 studies should not be assessed together. So here we wanted to look at the totality of the evidence base, so that includes phase 2 and phase 3 studies. We included any study in our quantitative synthesis if it was similar in terms of populations, outcomes, and interventions. And just to note that due to smaller sample sizes or larger variances, which is more common in the phase 2 trials, in the quantitative synthesis, these trials would be given less weight. And finally, a comment that galcanezumab should not be included in the review at this time because it was further behind in its development. But we argue that stakeholders are beginning to make decisions about arenemab and thinking about the other CGRP inhibitors as well. But we do know that there was a limited amount of data at this time. So galcanezumab was included in our clinical review, but it's not included in our economic evaluation. So I'll stop there.
Are there any questions for Dr. Ellis, panelists? Thank you.
Thanks.
So I'd like to move on to our next presentation of the evidence with Dr. Suri Walton from University of Illinois, Chicago. Dr. Walton.
Hi, good morning, everybody. So I'm going to start by just acknowledging my colleague Todd Lee at UIC, who was a co-leader on this project. Also, some kind of key team input came from Danny Kwok, who was an RA for us there. Also, Varun, Kumar, and Rick Chapman from ICER, and really the whole ICER team had useful input for this. And none of us have any conflicts of interest relevant to this report. So the primary objective of the economic model here was, in the base case especially, was to estimate the cost effectiveness of arenemab and fremonizumab compared to no preventive treatment for patients with chronic and episodic migraines for whom other preventive migraine medications had failed. So that was the target group here. And we have separate models for chronic and separate inputs into chronic and episodic. So I'll get into the methods. So this was a semi-Markov model with time-dependent efficacy and mortality rates, slight changes in the efficacy across months in the first few months, and mortality rates, very slight changes in the second year versus the first year. The setting was the United States. We took a health sector perspective. We used a time horizon of 2 years, and we based that on because of high discontinuation rates generally seen, and mainly because of the literature, past models that use that time horizon. If we vary the time horizon in our model, it really doesn't have a big impact, but we view this as a 2-year model. We have a 3% discount rate per year, a cycle length of 1 month, and the primary outcomes are costs, quality-adjusted life years. We also have migraine days reduced, and the primary outcome is cost per quality-adjusted life year gained. Here's just some summary demographics of sort of the prevalent population of chronic and episodic patients that we thought would be the best fit. The model, which primarily impacts the mortality rates. So you can see about 40 years old, mostly female, and you can also see here the mean migraine days per month in chronic and episodic is sort of a baseline. These are the drug regimens that fed into the efficacy values. Iranemab recently got approved, by the FDA at 70 and 140. And fremonizumab has a couple of different dosing regimens, but we picked the ones that had the highest efficacy rates from the trials. So that's why we chose these. Here is just kind of an overview of the model, relatively simple model. In the treatment arm, you start on a CGRP inhibitor. You can discontinue. When you discontinue, you go to no preventive treatment. And again, this is to reflect patients that have already tried and failed therapy. So the view here is if they fail on CGRPs, they just go to no preventive treatment. And the other comparator arm, you just have no preventive treatment, and then there's a small potential for death on both sides of the model. So specifically, these model transitions, the discontinuation rates come from the clinical trials, from an NMA of clinical trials, and the mortality rates come from CDC, age and gender-adjusted CDC rates. So here are the key assumptions. First, that the CGRP inhibitors have no direct effect on mortality, outcomes, or cost of treating underlying conditions other than migraines. So the treatment effect is all coming through the impact on migraines. The effect of migraine days on utilities is based on disutility weights for mild, moderate, and severe migraine days from the literature, and I'm going to show you those later. Changes in the distribution of mild, moderate, and severe migraine days. So a treatment effect can reduce migraine days. A treatment effect can also reduce the frequency distribution of severe relative to moderate and mild. And we had some available data come in from fremonizumab to include that sort of treatment effect. So we did that, and we also took that same effect essentially and gave it to iranemab. We didn't have data for iranemab at that level of detail. Reduction in migraine days resulted in proportional reductions in other forms of healthcare utilization, such as hospitalizations, ED visits, and PCP visits. So our best way to estimate this was to tie those resources uses to number of migraine days and then proportionally reduce them as part of the treatment effect in terms of costs. The AEs that we saw in the clinical trials were relatively mild, but worth noting. So we put those in the model and we assigned them a cost of a primary care physician office visit, a modest cost there, and an assumed mild disutility of 0.05. So just to try to kind of include the idea of adverse events in the model. And the cost of CGRPs were based on iranemab's initial launch price, which we discounted by 27%, and then we rounded it, and we applied that to both drugs. So here's some of description of the inputs. First one here is discontinuation rates seen in chronic and episodic. Again, these came from an NMA, about 3% per month in the chronic for iranemab and 6% in fremonizumab, and a little bit higher in the episodic model. Here's just again the costs, which came out to be $5,000 after we took the price and discounted it and rounded it. We also included a small administration fee just in the first month for the drugs. So one key model input here is the use of acute drugs. And here you can see the baseline rates that we took from the literature projected for like a prevalent population. We have a cost per day for acute medications that came from the literature. And then we have reductions, separate reductions of the days of use that came from an NMA. That kind of information was available from the clinical trials. So here you can see it for acute versus, in chronic versus episodic. Again, in addition to the reduction in the acute medication use, there's also some reduction in other healthcare resource use that's proportional to the migraine days. And this just shows the cost per month associated with these visits at baseline to give you a sense of how much these contribute to costs. And down below, there's some more detail. These are costly events, but they're relatively rare. So in the model, they're not a large monthly cost, but worth considering. Here are the adverse event rates. again, seen in the trials, and the costs that are associated with them based on the assigned cost that we use of a physician office visit. Again, relatively small. So here are the utilities that are a really key input into the model. We got the distribution of severity of migraine days from the literature, best source we could find. It's worth noting that this utility associated with severe migraine day of 0.44 is actually a very severe condition. If you compare it with utility scores, it sort of lines up with very severe heart failure. It's below that for blindness. It's near that for a acute psychosis. So it has some face validity in terms of just comparing this with similar numbers from very severe conditions. We got this from the literature. So here are the results. In the chronic model for Arenumab, we ended up with $90,000 per quality-adjusted life year. And these are rounded to the 10,000 to kind of protect some of the redacted data that we used. And for Imnizumab, it was $120,000. And in the in the episodic patient population, ended up being $150,000 or very near that as an average value for both. So we conducted a number of sensitivity analyses. These show one-way sensitivity analyses. And I'm just going to show this for Arenumab for episodic. It was very similar across the drugs and across the models in terms of what inputs were important. So first of all, the migraine day reduction itself was a key, very important input, not surprising. Drug costs, migraine day utility, and migraine-free day utility, also relatively important variables. And then the impact of variation in the rest of the variables was lower from there. This summarizes a probabilistic sensitivity analysis. You kind of take variation and a lot of possible variation in the inputs and run a bunch of simulations. And this tells you of, say, 10,000 simulations, what percent were below, of the ICERs from those simulations were below a particular value. So at 100,000, you can see that only 23% for Imnizumab was below that, although 66.8% were below 100,000 for the Arenumab. If you go to 150,000, you see that the majority of times the simulation had favorable incremental cost utility ratios at 150,000, meaning they were below 150,000. So it's very likely from the data, at least from the model, that the incremental ratio would be below 150,000. It's a little different in the episodic migraine. We had that the sort of mean value was 150,000, but if you take potential variation again in the inputs, it turns out that the majority of time the incremental cost ratios are a little bit above 150,000 in episodic. We also ran some scenario analyses, and we ran a variety, but we felt like these were the two to highlight. So one is taking patients and comparing CGRPs to sort of other available treatments that are currently on the market. And we used a mix of treatments and NMA results, and we found that relative to that, we have very high incremental cost utility ratios of choosing CGRPs in a general patient population versus the currently available treatments. On the other end of the spectrum, if we include the impact of reduced migraine days on productivity, we took some estimates from the literature there, we get much more favorable cost utility ratios. So it's $50,000 in the Arenumab and $80,000 in the Imnizumab, lower for both. And even in the episodic, where, remember, we were at 150,000, if we include the productivity effects, we're down to 110,000. So here are the limitations, our two key ones. The models are inherently based on clinical trial data over relatively short time periods that may not reflect longer time horizons or real-world use. And the model applies to an average patient with chronic or episodic migraine for whom other preventive treatment options have failed but may not reflect particular subpopulations. These are kind of generally true of models. So here are some public comments relative to the model. First is that a societal perspective should be employed, as CGRPs will have productivity effects. So ICER focuses on a health sector perspective as its base case model. We did do a scenario with productivity effects, and you can see it does have an important impact and lowers the incremental cost utility ratios. CGRPs will help with depression as well as migraine. We actually ran a scenario taking some available data on that, and there is some evidence suggesting that, but it had a relatively small effect on the incremental cost utility ratio, but there does seem to be some data that this is true. CGRPs will reduce issues with opioid addiction. This may be true. This is a thing that's hard to get good data on a treatment effect on the impact on future opioid addiction. But it's worth mentioning. We didn't include it because we didn't have good enough evidence to try to model that. Non-responders will discontinue, leaving only responders, such that long-run cost effectiveness of CGRPs will improve over time. We actually don't see this in the data. So if this were true, and there are high discontinuation rates, you'd expect to see the efficacy of the remaining patients really increase over time. And there just isn't data that shows that. So we've also heard from clinicians that responders may discontinue. So that's maybe an open question. But we don't see evidence for that. And CGRPs may impact schooling achievement and impact future employment status, including job promotions. This I just put out there because I think that this might be possible, and maybe for particular patient populations, and it's kind of worth thinking about. This is something that it's very hard to get evidence on this, especially for kind of the general patient population. And so we didn't have a way to model that, but I think it is worth thinking about and might be true for particular subpopulations, but hard to establish that empirically. So in summary, arenyumab and fremonizumab are projected to reduce migraine days and improve patient health. At currently expected discounted prices, arenyumab and fremonizumab are projected to have incremental cost effectiveness ratios essentially below $150,000 in chronic migraine, for whom, and this is in patients for whom other preventive therapy has failed. CGRPs are expected to have cost effectiveness ratios around, but likely above $150,000 when used in patients for whom prior treatment therapy has failed in episodic. If we include productivity effects in CGRPs, we get more favorable incremental cost effectiveness ratios. However, CGRPs compared to currently available therapies are projected to have incremental cost effectiveness ratios that are well above current thresholds. I believe that's it.
Thank you.
Yeah.
Are there any questions from the panelists or our experts? Any comments on the evidence presented?
Yep.
Thanks for that presentation. A lot of effort clearly went into those analyses. Could you talk a little bit more about the source for the utility values that you included and how that was done and where it came from? And also, one other question, but maybe I'll ask that after the utility question.
I'm just going to go back to that slide. The utility scores came from a study by Zhu, 2011. So what's the exact question there?
How did they assess the utilities among what kind of people,
these are,
how many people?
I'm not going to know the exact specifics on this, unfortunately. But this was a general study of utility scores associated with description of this health state of having a severe migraine day, similar to how other utilities are done. What I don't recall is whether this was a time trade-off or a standard gamble utility. I don't have that level of detail.
Do you know how many people they assessed? Were they migraine sufferers, people reading descriptions of migraines?
Again, I apologize. I'm going to have to look that up, and I can.
We'll try to look it up.
Yeah, we can look that up. Again, these utility scores, to me, have pretty good face validity in terms of being compared to other utility scores and other chronic conditions, which we looked at. So 0.44 is a very low utility score.
Yes, I know.
Yeah.
That's one of the reasons I'm asking.
Yeah.
And then, second question is about the costs of episodic migraine therapy. You said came from the literature. Can you talk a little more about
the
that?
cost of episodic?
Like treatments, acute treatments for migraine was $24 a day, but I'm curious.
Yeah, that came, again, from a paper from Masali. So that, I believe, was based on patient survey, but it just took a mix of treatments that were commonly used by patients, and then we took a market price for that, or they had taken a market price for that and assigned it to that mix and gotten a cost per day.
I guess my question is, when you did the pricing on the new drugs of interest in the analysis, you applied a discount rate to that, and I'm wondering if there was any, like discounting or other assessment of the $24 a day price, because it seems a bit high.
I think that, again, we took this from the other study. I think they were trying to have a realistic cost. Drug prices are something that are hard to get exact data on. So I mean, it's a valid point. I would say that the impact of this number on the model is very small. So if you took a lower value of this or a higher value of this, it has a relatively small impact.
Okay, thanks.
The utility score does have a big impact, so that's an important.
Thank you for the oh, sorry, I have a question.
I have another question, sorry.
Thank you for the presentation. I just want to clarify, when we're talking about patients who have failed prior preventive therapies, we're talking about patients who have failed 1, 2, or 3 preventive therapies, because we have no data on patients who have failed 4 or more preventive therapies because they were excluded from trials.
That's correct. So that we only have the data available in the clinical trials, and it's a point that was brought up in the first presentation, but you could add it as a limitation here. So we got data conditional on failing at least 1 treatment as our best guess at this number. But
right, at least 1, but no more than 3.
Yeah, from whatever was in the trial, and that was generally what was in the trial.
Say.
The one question that I had was, in your sensitivity analysis, did you take a look at if the efficacy of the treatments were lower than in real life than seen in the trials? And this is from many other disease processes where we know that patients who enroll in trials are more compliant, different in some way, and that in the real world, the efficacy seen, and this is seen mostly in kind of the other drugs where we have a lot more experience, like statins, the actual efficacy seen in the real world is actually substantially lower, and actually lower by a predictable amount than what's seen in the original research trials.
So here, the top bar in this one-way sensitivity analysis shows you the impact on the incremental cost effectiveness ratio if you vary the efficacy, and it has a very big impact. So if there are differences in efficacy in the real world, they will have very big impacts on this. So it's a good point. We did do it.
Can you tell me the range of efficacy that you varied in the sensitivity analysis in the bars that we see?
I believe this is taken from the standard deviations from the NMA, and so it's applying a confidence interval to that. And there's a little, there's a big impact from it. Yeah. So I can't get into the redacted data, but having a difference of 1 migraine day, for example, is a very large difference in the incremental cost effectiveness ratio.
Hi, this is David Rand. I just wanted to go over from the Zhu paper what it says in the methods, which is 330 20 to 65-year-old adults in good physical health who had 1 to 6 moderate to severe migraine attacks per month in the 2 months prior to the visit. This was done in the setting of a trial of acute migraine treatment, so they were examining what their utilities were using EQ5D during the acute attack, then they were treated and better, and comparing that to how they were after the treatment.
Thank you. I actually have a question that I would actually like the experts to comment on as well. This issue of discontinuation was quite interesting. It seems as if patients discontinue for a variety of reasons, some because the drug is not working, some because of side effects, and we've heard recently about these patients who actually respond and then discontinue. And are they discontinuing because they have some sort of perceived persistent benefit? And I'd like to know what role that plays in clinical practice. How often is that phenomena observed?
So it's really hard to know the exact numbers because no one's actually followed in that way. And so it really comes from personal experience. So I think if I look at my numbers of new patients and the numbers who come back, only a small number come back for that second visit. When I first started working, I had free time. So if a patient didn't come back, I'd call them up and I'd say, "Why aren't you coming back?" And they would tell me, "Well, I'm better. So why do I don't need to come back?" And then over the years, I've now worked at Kaiser for nearly 15 years. And I will see patients back like a year later, and just like this last week, someone came back 10 years later. And they came back 10 years later because they used their preventative for a while, and the headache went away, so they stopped it, and the headache recently came back, and so they wanted treatment. But it's hard because, I don't have numbers for that. Certainly, some patients will say, well, I've tried so many, I'll see someone back and they'll say, well, I tried so many things, I stopped it because it didn't work, and I figured, why should I come back? So I'm coming back for something that's new. But in general, the more frequent someone has, the more frequent and disabling a migraine is, the more likely they will come back if they've stopped a preventative because they want to try something else. But there's no numbers that can be captured with that. But a good number of patients do, and I keep my patient lists, and it's now in the computer. So a good number of patients don't come back because they got better, and they stop it because they figure, well, I'm better. Do I really need to continue? And then some will try and they'll stop it, and then on their own they'll say, oh, the headache came back, so they'll restart the medication. But unlike, we have no numbers for that we could find in any case. Because in general, patients don't want to continue to take a medication if there isn't a benefit, and on their own, they will stop the medication. And when we counsel them, we tell them about, is this something you can stop, or you have to taper, or to sort of give them that sense. And then some patients, when they come back, they can discontinue, they actually come back and they're doing really well, and they're rarely having a migraine, and they're back 6 to 9 months, and they say, oh, can I stop? Or I will ask them, do you want to stop? And again, we don't have any numbers about, when it's physician-directed about stopping the preventative, how many come back or how many do.
And is it generally the expectation that when you start someone on a preventive that they will continue on it, or is there an expectation that at certain points you try to wean off and see how they do?
So the expectation when I tell patients is that if this really works for you, that anywhere from 6 to 12 months, depending on how they do, that we can wean off the medication and see how they do. Some patients who've really had tons of migraines don't want to wean off ever. They want to stay on, and that's fine. Some patients really want to wean off, and they drive it a little bit more. But I tell patients that this is not lifelong. And it's not a lifelong treatment because for many people with migraine, so migraine is a lifelong disorder whose natural history is characterized by fluctuations. You'll have periods when you have more migraine, you'll have periods when you have less migraine. Everyone's triggers are different. I mean, for some people, until this thing gets over in their life, they're just going to have lots of headaches. For some people, you can never find that treatment. The best data I found was a recent study from electronic diaries that people use to record their migraines that found that people who have chronic migraine, just natural history without any treatment, sort of fluctuate between the chronic migraine state and the episodic migraine state. It's not looking at anything like disability or anything less. It's just looking at headache days. People with episodic migraine tend not to cross that border into chronic migraine. Natural history other studies tell us if you're in the high frequency role, which you can't actually distinguish with the numbers we have, where you have, you're not quite chronic migraine, that you'll have a tendency to go forward. And so because there's so many factors, triggers that vary per patient, for many patients, you have a lot of migraine, you use a preventative, you get better, you figure out your triggers, you address those triggers, and now you come off. And so, that's why understanding yourself, behavioral migraine management, trigger identification, that's what provides a lifelong management for migraine. For some patients, not all, some patients need lifelong, or not lifelong, but decades of prevention. But people want to come off because they're better. There's also natural history just to migraine frequency based on prevalent studies. So, particularly you see this for women. You have this curve in the 20s and 30s, and post-menopause headache goes down. And that it just does on its own without any treatment forever. So there's never that sense. I'm sorry, this is very long-winded, but there's never that sense that someone's going to be lifelong on treatment for migraine.
Thank you. Thank you. We have time for one more question. I think Jeff's board is up. Oh, I didn't see yours, Kim.
Thank you. I'll make this quick. Thank you very much for the presentation of the economic evidence. I wanted to see if I understood it correctly. When considering the value for money of the CGRP inhibitors as preventative treatments, the answer to the question, are they cost effective, depends on what you're comparing them to. Is that right?
Definitely. So it always depends on what your threshold is for cost effectiveness, right? When we have a different model in chronic and episodic, in the chronic model relative to no treatment, it appears to be below 150,000. In the episodic, it's a little bit above 150,000 relative to no treatment. When you take these and compare them in a general patient population relative to like the prevalent treatment mix, they're very much not cost effective.
Okay, so I just got word from the holder of the clock that we have time for a few more questions. I think, Kim, your board was up?
Yeah, I was, this is probably more for the experts, but I think 17% of patients discontinued because of nasopharyngitis is like the overwhelming side effect. How significant is that? I mean, how do they really present?
So I haven't prescribed, because these are new and I haven't used them yet. I don't know exactly what that means for the patients. It's actually not one of the side effects that's listed on the FDA label, which is just injection site and constipation. So when I saw that, I am wondering, I think I had a few patients who were in the trial, and so I would ask them, do they know what it is? But I'm really not sure. Maybe, I don't know if one of the manufacturer, who's a company representative, might know that.
We'll hear from them in a bit. Andrew, I think that your board was up. Did you want to make a comment or have a question?
I did. I just wanted to
Kevin,
add
sorry.
into what you had been talking about, the issue of discontinuation rates. And some survey data that we've looked at showed among migraine patients that the number one reason they would discontinue treatment was lack of efficacy. And so knowing that that's the case, it is our assessment that one of the flaws of the model or concerns we have about it is that it doesn't show that those who are on the CGRPs and some show that they're not getting a response, we expect that over a certain period of months they would drop off. And so we think that over time in the real world, different from the clinical trials, where I think many people sign up and whether they're seeing benefit or not, they see it through to the end of that clinical trial. It's sort of what they signed up to do. But in the real world, we anticipate people will, after some period of months, determine with their physicians, is this or is this not working for me? And for those who it is not working, we don't expect them to continue the treatment. And I think that over time, that will increase the rate of the efficacy of these medicines that may not have been seen in the trials, but we anticipate that in the real world. So we anticipate that as something that the model didn't accurately capture here.
So we've already talked a lot about this, but this was just a 2-year model, and you could see there's a lot of reasons for discontinuation. And so we felt comfortable about that time horizon for that. In all other treatments, and Botox in particular comes to mind, in longer periods of time, you don't see this increase in efficacy across time related to discontinuation. That could be true in the CGRPs, but there isn't any reason to expect that to be true given the data that's there.
Mike?
I have two questions. The first is to use a metric that you haven't been using, and this is for the clinical experts. If you use the conventional wisdom around response rate of this group of drugs is around 20%, folks have said. You can correct me if that's wrong, but this is what I've picked up around Westwood at any rate. It raises the issue, if you brought a patient in during an attack and measured the peptide, would you be able to more focus the use of the drug, use it in a more personalized way? Because clearly migraine is not one disease, it's multifactorial, and maybe a number of mechanisms create this constellation of symptoms. So is there any practicality to actually bringing a patient in and measuring the peptide to see if the drug should be used or not?
So if I remember correctly, the changes in CGRP are seen across all migraine patients. And so I don't think it is the actual, I don't think that will help. And also CGRP is a transmitter in all primary nociceptive sensory, the nociceptive sensory afferents. And so it's not just restricted to the head. And it will be interesting I don't think anyone's done any studies in other pain conditions, but there's never been the sense that blockade of this system. Again, no one studied this, so this is actually an interesting question. Will it have a response to other type of pain? Certainly if you look at the triptans, again, serotonin agonists, they help migraine, they also help cranial pain, but they don't help pain everywhere, even though you have these receptors on primary, are involved in transmission of nociception throughout the neuroaxis. So why are these, I think, there are a lot of mechanisms that have been proposed, but we still don't have a way of picking out what's going to help which person, because you're exactly right, the response rates seem to be in line with the other preventatives, and why one thing helps one patient and it doesn't help another patient likely reflects its polygenetic pathophysiology that differs in people.
I think it's also hard, though, in folks who have multiple comorbidities that involve pain. So isolating that just to the migraine folks is a bit kind of difficult as well to know if there was a difference in the CGRP levels. Is it significant, or is it because there is something else going on in that patient, unless that patient purely has no other comorbidities and only migraine?
My second question should be quick. Is there a clinical way of tracking patients who have, let's say, like a partial response? In other words, do these drugs behave this way, or any of the management? In other words, a person still has a headache but can function at work today, and the intervention did in fact do that.
So clinically, we do by using disability scales. So when we talk to patients, my practice is headache focused, so all of my patients get a disability scale. So where it looks at how many days with migraine and how much disability that they've had. And so there are ways to do this. It's, as was emphasized in the excellent report, this is not uniformly tracked. In the more recent studies, you have a little bit more data, but you can look at that. And that's one of the, when we talk to a patient about changing, or because sometimes patients are happy and I'm not happy, because I look at their disability stuff and say, hey, that we use that as a marker for treatment response. And I did want to echo what Kevin said, because he's absolutely right. Patients stop when it's not effective, but I wouldn't expect anyone to use something for more than like 3 months. If it's not going to, sort of 2-3 months, if it's not effective, why use it more? Because we can go to something else. It might be a little effective, you might need to do something else if you're at the maximum tolerated dose. But, I'm not going to use something for 6 months to a year and then tell a patient, that's too much time. It's too many headaches, too much, disability. It really is disability.
So I think we're closing.
Sorry, I just wanted to circle back to the issue of whether in the real world with longer term use you'd see discontinuation such that efficacy improves. we don't have a ton of data on this, but we do have the open label extension of the aranumab trial, where the decrease in migraine days really looks very similar to what was seen during the randomized phase. So I think that supports your point that we're not seeing that so much. It doesn't mean it's not ever happening, but at least we're not finding the data to support this idea that as people are using these over time, the efficacy among the continued users is going way up. I'm not sure what to make of that.
I agree. So if I have a patient has been on years on a preventative, I don't get the sense that later on it's going to be much better. You know, typically if they stay on it for years, they're sort of happy with where they're at and they don't want to try anything else. And so the best stories are people with chronic migraine who had really, really, really bad migraine. Now they still have headache every single day, but they have, 4 migraines a month that are easily treated, and that's what they tend to stay until you put on natural history with age. So the one thing that will lead to it will be natural history with age. Clearly, postmenopausal women, clearly there's a decrease in migraine if you look at those curves. That is what will lead to discontinuation. Or if they're stressful life, if there was something that was triggering it, retirement, but that also comes in that same age range. So that's when you start to see them get better, and that's when you'll stop. But I don't think it's the medicine working better. I think it's the natural history.
Save last question.
Oh, thank you for letting me have the last word. So this is another modeling question that specifically gets to what Dr. Petrovic was talking about in terms of the fluctuating disease course. And I was wondering if the models actually had any sort of accounting for regression to the mean, that most of the time patients are coming to the doctors when things are not going well. This is a naturally fluctuating disease course, which means even without treatment, probably things would have gotten better over time because we are not randomly seeing things. Now, on average, certainly it's not going to be true for everybody, but on average, that's what we would expect across most of these fluctuating diseases. And I was wondering if that was accounted for in the model.
Only in that we have a relatively short time horizon, partly for these considerations. And then I think that potentially explains some of the placebo effect, which is in the comparator arm, which impacts the model.
Okay.
So I will. Well, you put your thing.
I wanted to add that with migraine, it's also common if it's not treated that it may spiral out of control and from episodic become chronic. Is that what you're going to say?
So that was one of the things.
Okay, go ahead.
So there are a couple things I was going to say. So there's a group of people with migraine that don't respond to anything, and they may continue for years. But I do think that that's a very good point, because when people with migraine have had migraine, they go to see a doctor when it's worse. And a lot of the triggers, so you have weather triggers for migraine, you have stressful life event triggers for migraine, and many of those are going to be on a shorter time course than 2 years. So I recently had a patient whose migraine flared because of a death of a close relative. And so patient died, headache got better, she went through the grieving process, there were a couple of things, and now she is better, and she is better she's better 6 to 8 weeks later. Was it my occipital nerve block that made it better? Was the fact that she had a religious experience with her relative that made it better? Was it the natural course of grieving? We don't know, but that is correct. I mean, if you talk to neurology residents, they have their most migraines during their neurology residency, and then after residency, they have fewer migraines.
With that comment.
I don't know if you remember, I actually developed migraines when I was at my Kaiser residency.
Now she's program director.
She was my program director.
So I think that's an excellent point, because we're always wondering about that. And so I think clinical trials try to address that by having it sort of a run-in period where they try to see, but we don't know. Are you more likely to want to go to clinical trial because you're having more migraines at this point in life? You just don't know. It has a natural history that we know, but it's so variable for individual patients. Everybody is different.
Thank you. So I'd like to actually ask our manufacturer representatives to come to the table and also invite Dr. Ellis and Dr. Walton to also join us as we continue this next part of our discussion. We would ask that the manufacturer representatives disclose their conflict of interest, make sure that you adhere to the 5-minute time limit, and hopefully you've also left some time for questions in that comment. So we would like to start with Dr. Sapra from Amgen.
Yes. Hi. Good morning. I'm Sandhya Sapra. I've been working in migraine and Amgen for the past 4 years. And during these past 4 years, I've worked very closely with patients and their physicians. And the pain and suffering that I've witnessed has been a truly humbling experience. This sentiment is reflected in the title of a 2018 editorial in the Journal of Headache and Pain, which states that migraine is the first cause of disability in under 50s. Will health politicians now take notice? This article further states that migraine ranks second only after low back pain in terms of years lived with disability. Before getting into Amgen's comments on the revised report, I'd like to talk about a few patient experiences that I've heard that really bring home to me how debilitating this disease is. With almost every migraine, patients experience excruciating pain, which some describe as being hit in the head with a baseball bat. Migraine robs patients of their lives, makes it impossible for them to interact with their friends and family, takes them out of work. Migraine patients are unable to do many activities that you and I take for granted, or they suffer through these activities. While this is their reality, imagine yourself, imagine not being able to drive, imagine a mom not being able to bend over to pick up a child. While current preventive therapies work for some patients, like we just heard, others suffer side effects, such as severe cognitive dysfunction, trouble with their memory, mental fog. Almost half of these patients who start treatment stop the treatment because they do not get the benefit or they suffer from side effects. Migraine patients need options. We are thrilled that Aimovig is now available to patients as the first and only FDA-approved therapy specifically designed to block the receptor. Aimovig has demonstrated efficacy in patients that have failed other preventative therapies. Aimovig patients are those who have experienced migraine prevention and yet continue to suffer the burden of frequent migraine. In clinical trials, Aimovig, which is once a month sub-Q injection, demonstrated significant reductions against placebo in migraine days, and therefore allowing patients to reduce the amount of acute medications they were using. It reduced the impact of migraine on normal activities that patients told us was very hard for them, those very activities that I shared with you earlier, that many of us take for granted. We commend ICER on its collaborative effort to secure feedback from stakeholders and the 200-plus patient advocates who have engaged and commented now on ICER's revised report. However, the revised report undervalues Aimovig in this healthcare economic analysis in 3 fundamental ways. The three points that I'd like to make here are assuming placebo-adjusted efficacy numbers, underestimating migraine-related emergency and hospitalization rates, and most importantly, underestimating the impact of a migraine on a patient's quality of life. So what do we mean when we say placebo-adjusted efficacy? In clinical practice, patients do not get placebo or placebo injections. So subtracting that number, that placebo number from Aimovig efficacy underestimates the benefit that Aimovig delivers. At a minimum, the non-placebo subtracted efficacy should be reflected in the final report. We also heard a comment about the OLE data and that how there is not a sustained or a durable, there's not a sustained effect or an increasing effect with Aimovig as patients stay on treatment. I just would like to note that the data that's been published is actually the 70 milligram data and the 140 milligram data, which shows that in patients who stay on Aimovig, and actually 80% of these patients stay on treatment by the end of year 1. And some of those dropouts are because of limited country participation and things like that. So there's a high retention rate in these clinical studies. And we see that in some of as these patients stay on treatment and the non-responders fall out, the efficacy improves. The second point that I'd like to make is that the revised report underestimates hospitalization and ER rates by using the entire prevalent migraine population. The actual patients who need prevention, that is the 4+, are only 1/3 of this patient population. To summarize this point, migraine patients who need prevention have a higher rate of emergency room and hospitalization than in the revised report. The final report should correct for these rates. The most important point, the utility values that was under discussion, or the quality of life data, is how we refer to it, in the revised report, comes from patients who do not even need preventive treatments. These patients have 2 to 3 migraines over a 3-month period and can be treated with over-the-counter therapies. The report should accurately reflect the quality of life of patients with a much higher frequency of migraine, ranging anywhere from 4 to 30 migraine days a month, the kind of patients that were included in the CGRP clinical trials.
Thank you, Dr. Sapra. Is that your last point?
I'll just make one more point quickly. The most important area of consideration is to incorporate the patient indirect costs into base case assessment. The revised report undervalues this because it excludes these costs, and I'm talking about the cost of missed work days and also days impacted by migraine. When these costs are actually included in the scenario analysis,
Unfortunately, we're going to have to move on.
I'm sorry, I see that. Okay.
All right.
I'm happy to take questions, though, if it was...
Are there any questions or comments on Dr. Sapra's comments?
So I just wanted to comment on the placebo effect. So you're referring to a trial that was in part sponsored by Amgen that included the value of placebo in the value of the therapy. And in my calculations from that assumed that if this drug worked not at all, it would be worth $5,300 to $8,700 per year if it were, for instance, a saline injection. So I just want to make clear what the assumption of including placebo effect would be. If I were bringing patients into my office once a month and injecting them with saline and getting them that placebo effect, this would assume that it was worth on the order of $7,000. It's unheard of to assume placebo effect in thinking about the value of a drug. We can get placebo for patients with migraine much cheaper than by doing an injection with a CGRP inhibitor.
So I think I'll just make 2 points. The report that was published, by Lipton et al., when you actually remove the placebo effect, the placebo effect is included and you model it out, the value of Aimovig there was from about $15,000 to $24,000. When the placebo effect is actually subtracted from the efficacy, the value still holds at $7,000. And like I think we've discussed this before in our previous calls as well, I think these are placebo-controlled trials, correct? And you see both absolute effects and relative effects. And Dr. Walton, you just spoke about how important a one-day migraine difference is. And what we're asking is that you provide both numbers. You use both the relative rates, and at least at a minimum in a scenario analysis, use the absolute effects as well. Because we really can't tell right now. This disease has a huge placebo effect. The efficacy, we believe, will actually be somewhere in between the relative effects and the placebo effects.
Dr. Walton.
That's our belief.
It's just so... Hello? Yeah. It's just so against science to include the placebo effect. So very slippery slope. The reason we have placebo-controlled trials is to control for what would happen if you did nothing and to scientifically prove that you have efficacy. So it's just mind-boggling to throw that away or to say that we should include a placebo effect, which could be a regression to the mean, could be a natural course of the disease, could be drinking a soda pop in the morning.
It's really
not something we can prove.
I think we're going to move on. Dr. Cohen, Dr. Joshua Cohen from Teva, if you could.
Good morning. My name is Joshua Cohen, and I'm a physician, board certified in headache medicine and neurology, with nearly a decade of clinical practice experience managing patients with migraine and other headache diseases. And I'm also a patient with migraine. I'm here in my current role as therapeutic area lead for migraine and headache at Teva Pharmaceuticals, and will be integrating my clinical practice experience into my comments as well. Teva fully agrees with ICER's assessment that the clinical studies of CGRP inhibitor therapies demonstrate clinically meaningful benefits in patients with chronic and episodic migraine. For example, fremanezumab phase 3 trials in episodic and chronic migraine met statistical significance for all 25 primary and secondary pre-specified endpoints. This demonstrates not only the strength of evidence for reducing headache and migraine days, but also the significant improvements in patients' quality of life, functioning, and disability status. The ICER analysis reports the pooled efficacy data on some of the key outcome measures, such as mean reduction in migraine days, across trials for fremanezumab and erenumab. It should be noted that the confidence intervals around these pool estimates on such key variables for included CGRP inhibitor therapies are wide. Therefore, we would like to encourage the decision makers to focus more on the overall value these CGRP inhibitors bring for migraine patients, as opposed to over-interpreting reported numerical differences in results for included CGRP inhibitors. We also agree with and support the overall conclusions drawn from the cost-effectiveness analyses, which highlighted the overall value of included CGRP inhibitor therapies, including fremanezumab, as preventive treatments for patients with migraine who have failed at least one prior preventive therapy. We believe, however, that the full value of fremanezumab therapy would be better captured in analyses derived from comparative effectiveness estimates that account for the differences in baseline migraine days observed across studies, as well as analyses that include data on disability, incorporate discontinuation rates for current preventive therapies as observed in real-world clinical practice, and consider the potential for improved adherence with CGRP inhibitor therapies. On the topic of the potential budget impact of introducing these therapies into the marketplace, we concur with ICER's assessment that their reports and result overestimate the actual number of patients eligible for migraine prevention with these therapies. As indicated in the report, ICER's estimate of treatment-eligible patients include those who are not actively seeking treatment, resulting in a target patient population of 5.6 million chronic and episodic migraine patients. This estimate is even higher than the upper bound of the range stated in the study by Burrell and colleagues cited in the ICER evidence report of 3.5 to 4.9 million prevention-treated patients. We suggest that ICER carefully weigh the implications of erring on the side of a higher estimate for the number of patients in the target treatment population prior to finalizing the evidence report. Overestimation will likely influence payers and may impose greater and unwarranted restrictions to patient access due to fears of inflated budget impact concerns. The unintended consequence of this could be that patients who are otherwise appropriate for these treatments will not be able to derive the benefit from them, as patients could limit patient access through overly restrictive criteria. We at Teva are excited to work with payers to ensure healthcare professionals and patients are able to have both access and choice in order to tailor preventive migraine treatment in line with individual patient needs to drive improved treatment outcomes. We thank ICER for providing this opportunity to voice our opinion on this important topic.
Thank you. Questions, comments? Dr. Walton, Dr. Ellis? Any response?
Yeah, I've got a comment or whatever. The marketing for this, at least that I've seen so far, is pretty much that this is a laser beam treatment, that you should ask your doctor about whether these drugs are right for you. And it's not, this is a drug that's to be used after you've tried a lot of other things. So I think the fears of the payers are probably legitimate. I had a question from our pharmacist saying, we're interested in maybe seeing who would be appropriate to treat. Can you send me 5 patients? And I said, well, yeah, let me just check my inbox in the last hour to send 5 patients, because that's what's happening. We're getting a huge number of questions. And so I get that the idea is that we're probably saying, well, using potentially numbers that are much higher, but the reality is it seems like what's out there right now is, this drug is for everybody, ask about it. So I think that there's some validity in being concerned about a large demand. I'm not saying it's right or wrong, but I think I push back a little bit. The fear that the payers has some legitimacy, because this is a bad disease with a brand new breakthrough drug that patients are going to want. And I get that it's, should be used appropriately, but that's kind of not what's out there. So it's sort of my reflection is I get what you say, and on the flip side, there's something to be said. So I'm going to kind of argue that I think they got it about right in some of these estimates, but it is, again, it's not just a hard and fast number. It'll come out in the discussion. But that's my thought, because my inbox is buzzing. I can check and see how many calls I got in the last hour.
Thank you for those comments, and I recognize the importance of what you're saying. We've actually looked at literature with IMS, as well as worked with a number of payers looking within their patient databases about who would actually be the target patient population. And if you use a failure of at least one prior preventive therapy, the numbers that we're finding and that the payers are finding in their own databases are well lower than this 5.6 million number that's currently in the report.
Thank you. Next up, we have Dr. Eric Perlman, Eli Lilly.
Thank you. My name is Eric Perlman, and like Josh, I am a board-certified neurologist and headache specialist. I have more gray hair and had been in practice for 20 years before joining Eli Lilly about 2.5 years ago. Thank you for the opportunity to provide comments on the ICER evidence report on calcitonin-related peptide inhibitors as preventive treatments for patients with episodic or chronic migraine. We at Eli Lilly and Company are committed to improving outcomes for patients with migraine, as well as to have a frank discussion on value, which should acknowledge and support the right of patients and physicians to choose the best therapy for each individual patient, including medicines that advance patient care and address unmet needs. We appreciate that the evidence report appropriately captures the physical, socioeconomic, and emotional impact of the disease. The report adequately acknowledges how migraine affects patients' lives, including the limitations of current preventive therapies, difficulties with access to care, and the impact to quality of life experienced by many patients with migraine. Lilly has completed a clinical trials program treating thousands of patients with migraine. The results of this program, in addition to the research programs recently completed by other pharmaceutical companies in the field, have generated great optimism among patients with this disease. We are encouraged by the effectiveness, tolerability, and safety demonstrated by the CGRP antibody class across thousands of patients enrolled in our clinical trials. We are optimistic that this class will provide an important new solution for patients living with migraine. At the time this review was initiated, CGRP inhibitors were not yet FDA approved, and there was limited information on which to base a comprehensive assessment of product efficacy and value. For these reasons, we requested that ICER delay conducting this review until results had been published for all pivotal trials for all CGRP inhibitors under evaluation. At minimum, we requested that galcanezumab be removed from this assessment until phase 3 randomized controlled trial data had been published in peer-reviewed journals. As noted already, data for 2 of the trials of galcanezumab were published in May 2018, just days before the release of the updated evidence report. If the assessment had been delayed by only a few months, this would have allowed for a more scientifically sound evaluation across all products being considered and would have greatly improved the transparency of the process, as all available data would then have been readily accessible to the public. In fact, in the report published, only phase 2b data for galcanezumab were used in the comparative clinical assessment, with a mention of phase 3 trials results in the appendix. And as has been updated in the current presentation, there were phase 3 trials added. While we acknowledge the data and confidence policy that ICER developed during this review, we believe that a redacted report would not meet the appropriate standards of transparency. In addition, it is our opinion that the current policy does not adequately mitigate the risk associated with jeopardizing future publications or regulatory discussions. We appreciate efforts to create a timely, transparent method for assessing value. However, we believe that to be a sound value determination, efforts must not only be comprehensive, but must be truly patient-centered. Given the challenges associated with interpreting the clinical results in this review, it will be important for ICER to be forthcoming about the associated limitations when communicating the findings with stakeholders. Thank you for your time, and I'll take questions.
Thank you, Dr. Perlman. Other questions? Comments? All right, thank you. And finally, Dr. Jonathan Kowalski from Allergan.
Can you hear me? I am an employee of Allergan and also a stockholder. Allergan is the manufacturer of Botox, onabotulinum toxin A, and we are also in late-stage development for new migraine treatments, including 2 orally administered CGRP inhibitors for both preventive and acute treatment indications. Thank you to the ICER staff and to the USC modeling team for your engagement during the review, and to the CTAF panel for the opportunity to speak today. The assessment of value is an important conversation, as is the need to increase the treatment of migraine with high-value care and to minimize the inappropriate or low-value care in migraine, such as the use of opioids, as ICER and CTAF highlighted in their 2014 report. As has been well documented today, and we'll hear more later from patients, migraine has substantial quality of life impacts and disability across the board. In particular, chronic migraine is a distinct disease impacting approximately 1% to 2% of the global migraine population and is approximately less than 10% of the overall migraine population. It's primarily differentiated from episodic migraine by its more debilitating disease. And individuals with chronic migraine experience frequent disabling migraine attacks. The published literature suggests today that approximately 75% of chronic migraine patients remain undiagnosed, and it's important that these patients can be identified in the future and receive optimal treatment. It's critical, therefore, overall, that both healthcare providers and patients have access to a range of treatment options so that patients and their physicians can determine together the best care to meet the unique situation and needs of an individual patient. Botox treatment is indicated for the prevention of headaches in adults with chronic migraine, defined as 15 days per month with headache lasting 4 hours a day or longer. Botox was the first approved preventive treatment for chronic migraine in 2010, and has demonstrated effectiveness in over 5,000 patients treated in both clinical and observational studies conducted by Allergan. Botox's effectiveness for the management of chronic migraine has been further reinforced through independent real-world experience, and in the U.S., over 2 million treatments given to 500,000 unique chronic migraine patients since its approval, and this may approximate to about 7% of the estimated chronic migraine population in the U.S. The PREEMPT phase 3 trials evaluated the efficacy and safety of 155 to 195 units of Botox treatment administered by a physician every 12 weeks, with nearly 1,400 patients enrolled in the PREEMPT studies and randomized. Botox treatment was shown to be effective and safe. In the pooled analyses of the PREEMPT trials, patients at baseline reported an average of approximately 19 migraine days over the preceding 28 days at baseline. At week 4 in the study, following 2 Botox treatments, 50% of patients achieved a 50% reduction from baseline in migraine days per month, which was statistically significantly different from placebo sham injection. Most notably, at 24 weeks, approximately 1 in 4 patients achieved at least a 75% reduction in migraine days from baseline. And that measurement was taken 12 weeks after the second Botox treatment. Moreover, statistically significant and clinically meaningful improvements from baseline compared to placebo were observed for other endpoints, including headache days, moderate to severe headache days, cumulative hours with migraine, and patient disability at 24 weeks. Efficacy was observed starting as early as week 1. The most common adverse events occurring in approximately less than 5% of patients included neck pain, injection site pain, eyelid ptosis, and were mild and transient in nature. The sustained long-term benefit beyond 2 treatment cycles was observed over an additional 32 weeks in an open-label extension study. Treatment-related adverse events, as well as discontinuation rates due to adverse events, were comparable to placebo sham injection, and adverse event rates were observed to decrease with each injection cycle. It should be noted that with continued treatment after 2 cycles in the open-label extension, that further responders and reduction in migraine days were observed. These observations were further confirmed and extended by the COMPEL study. This was a 2-year, multinational, multi-center, open-label, prospective long-term study. Botox treatment reduced headache days and patient disability throughout the 2 years of follow-up and 9 Botox treatments administered every 12 weeks.
So
Botox
Dr.
treatment
Kowalski,
was...
you're out
Okay.
of time now.
All right. I think in summary, Allergan agrees with ICER's conclusion that the comparative effectiveness of arunimab and frezimumab compared to Botox, that insufficient evidence exists to make a conclusion that there is a difference, and further that any conclusions are limited by remaining uncertainty about the long-term safety profile of arunimab or frezimumab.
Thank you. Are there any questions or comments? Are we breaking? Okay. Well, with that, then I think we're going to break for lunch.
No, patient.
Oh, sorry. Yeah, I might be getting hungry. I'm sorry. Patient comments, please.
I'm sorry, I don't know what the order of...
Yeah, hold on a second. Are you
My name
Katie
is
Golden?
Katie Golden.
Yes, please.
And I would actually prefer to address the panel face-to-face instead of in the back, if that is okay. Thank you. I don't want to waste my time. So while I'm walking, my name is Katie Golden. I have intractable chronic migraine disease. 7 years ago, right before my 30th birthday, I got a migraine attack that has never stopped. I have not been pain-free in 7 years. Right now, I have a level 6, but I'm pushing through because this is important. I was the youngest vice president of my company. I was getting my master's degree at Georgetown, and chronic migraine disease took that from me. I'm not the only one to have migraine take something from me, something from our lives. I have witnessed an entire migraine community engage with ICER in this 8-month process. We had record-breaking number of patients compelled to share their stories because we are so often stigmatized and overlooked. And with these new medications, there is such hope and promise, and we deserve the right to be heard, to have access, for it to be affordable, and for us to have a chance to regain some control in our lives. The job of ICER is to evaluate the cost effectiveness of arunimab today. I was in finance, so I relate to numbers. So I'm going to give you a few that relate to me personally. I was making 6 figures. That is not the case anymore. I'm not able to work a normal a normal, regular job. I have turned my life into patient advocacy. My average medical costs are $100,000 a year for the past 7 years. My out-of-pocket costs, $15,000, or $1,250 a month, or $41 per day is what I pay. If payers and insurance companies are worried about the influx of demand for CGRP inhibitors, as the gentleman mentioned recently in a comment, they need to take into account that patients who do respond well to CGRP, the overall cost over my lifetime, they will not be, I'm sorry, when sometimes I get a little foggy in my train of thought due to cognitive impairment. So I'm just going to move forward. Through the ICER process, I understand that you have to have quantifiable endpoints. However, how do you measure a life? That's basically what you're doing, and it's what it feels like you're doing to me. How do you measure Melissa Dwyer's life? At 22 years old, she had been turned away by many world-class facilities. Her friends had basically abandoned her. She had to drop out of college and spent years in bed. She had no hope. And on June 7th, 2013, she took her own life because she could not imagine living one more day with migraine disease. How do you measure her life? In our country, there is an opioid crisis and there is a pain crisis. And you can't address one without addressing the other. Many migraine patients currently use opioids because they've simply run out of options. I personally have used opioids in the past for pain management for chronic migraine, and I've done so responsibly. But on the flip side, I've lost a close friend, a very close friend, to the opioid epidemic. The ICER model fails to take into account that the use of CGRP inhibitors could decrease the use of opioids in our population. The life of my friend wasn't even considered in this calculation. Pain is pain. The cause of it doesn't matter. If there are treatment options available that would potentially improve someone's quality of life, then insurance companies, payers have an ethical obligation to value my life the exact same as they would for another patient who has a disabling and potentially life-altering disease. If I could only have one day, if I could have one day without a migraine, that would be life-changing to me. It is disappointing, I will wrap up very quickly as I see. It's disappointing that ICER did not include on this panel today, the voting panel, a headache specialist or a migraine patient. Some of you raised your hands that you are a migraine patient. However, many of you have medical degrees. It is also disappointing that of the patient comments, we were allotted 5 slots. One person personally could not come at the last minute due to a family medical issue, and yet we were not allowed to to bring in another patient. So we went from 5 patient voices to 4. So for a patient-centric world that we are supposed to live in, I just wanted to point out that it is disappointing, and I hope that in future that these things will be considered as well. And for migraine patients right now, this is not a moment, it's a movement, as Lin-Manuel Miranda says. This is not a moment, it's a movement. And so for us, we are here, we are fired up, we're ready to go, and we deserve access to CGRP medications. Thank you.
Thank you, Ms. Golden. Thank you for soldiering on in the midst of a migraine and providing such a real face. Next, we'll have...
That's a good question.
Oh.
Thank you for your comments. And if I represent consumers or patients on this panel, and have been a migraine sufferer. So there is someone here representing.
Thank you.
My question is, what drug are you taking that costs $100,000 a year? Like, what are your medical expenses?
My medical expenses include hospitalization. I typically have I average 5-day hospitalizations. Is a protocol that I work with my doctor of, sorry, let me start that again. My medical costs of $100,000 include 2 hospital stays. Each of those 2 stays are 5 days apiece where I get infusions of a cocktail of drugs. So that is a very large part of it. It is probably one of the things that has helped me the most to be more functional. And so I will continue to do it until there are better options. But then I'm on, multiple preventive medications. I need massage. Whether you consider, whether anybody else considers, but alternative methods, going to yoga class, because that helps me. So, a large chunk is that, and ER visits. I try very hard and I do what I can to stay out of the ER because that's the worst place for a patient, but those are costly as well.
Thank you.
Thank you.
Next, I'd like to ask Ms. Mary Franklin from the National Headache Foundation.
Adult size. Hi, I'm Mary Franklin, Executive Director of the National Headache Foundation. Prior to joining the foundation, I was on the staff of the Diamond Headache Clinic in Chicago, which is a tertiary headache center. So I may be a little jaded. I've seen patients at the worst. We didn't get too many patients that just had 1 or 2 headaches a month. And I want to express my appreciation on behalf of the many, many headache patients and the National Headache Foundation for being allowed to participate. My journey into headache medicine began in 1970 as a nurse, and it afforded me a front row seat to the evolution of migraine therapy. So I think I was selected for the historical part. Throughout my years, I witnessed frustration for patients, first of all, finding a headache specialist, getting an appropriate diagnosis, and then the lack of headache medications. I've seen frustration in physicians and other healthcare practitioners who did not have options to give these patients. I remember the days of ergot therapy, and I remember how wonderful in the mid-'70s when they found out serendipitously that propranolol was helping migraine patients. But our patients with asthma couldn't take them. There were so many other comorbidities that disallowed beta blocker therapy. And then we went on to calcium channel blockers. And then in the early 1990s, the triptans were introduced. And what a great day that was. But patients could not take them, or after a few years, the therapies were not effective. Then we went on to the anticonvulsants, and topiramate had its day, but it's got its range of side effects. Now we're on the brink of a new day for migraine disease. The enthusiasm and the anticipation of these new therapies is felt by patients, the patient advocacy groups, and the healthcare professionals who treat them. But what about the evaluation process on cost effectiveness? I must stress the heterogeneity of patients with migraine disease. We have chronic migraine defined as 15 more headaches per month. But what of the patient who has 8 to 12, 14 headaches, migraine days per month? The severity and disabilities experienced is the same as those with chronic migraine, and they are not eligible for the only drug approved for chronic migraine, Botox. The variance in response should be noted. Women do not respond to medications the same as men. Do the models used reflect the differences in response to abortive therapy? For those with frequent episodic migraine attacks, they may be hindered by insurance. That limits their use of triptans to 4 tablets or injections per month. Which headache do you choose? Is this a Sophie's choice? I don't take my Triptan for this headache, and by the time I do take the Triptan, it's out of control, so now I'm down for 2 to 3 headache days a month. The efficacy provided by the CGRPs and the low side effect profile made their approval greatly anticipated. It is important that these agents be accessible for patients with chronic and frequent episodic migraine. Recently, the National Headache Foundation conducted an online survey on meaningful relief. We received over 1,800 responses, and 2/3 of those respondents indicated they were not satisfied with their current treatment. The side effects were the most cited reason for their dissatisfaction. We are happy and anticipating great response to the CGRPs because of the low side effect profile. And if you have drugs that have a low side effect profile, you have better patient compliance. One concern about this evaluation process is the use of step therapy, which requires patients to try and fail other therapies before prescribing a CGRP. The patient that's coming to the tertiary headache center and neurologist, they have tried many of these therapies and have failed. I don't want them to have more dissatisfaction. I want to give them hope. I want to see patients live full lives. Katie eloquently and passionately described her journey. I don't want to hear that again. I want patients to get help. And I've been around for a long time, and I've seen a lot of patients fail. I've seen patients who have lost relationships, jobs, careers. So I'm asking, please help these patients.
Thank you for that, especially for the overview and a quick journey through sort of the development of these therapies. I wonder how often you think it's the case that access, for whatever reason, cost, planage, whatever, is access to a therapy that actually works is the dominant issue for your patients.
I can't put a number, but I know it's overwhelming. We have, when I was at the Diamond Headache Clinic, we have an inpatient unit, and it was so frustrating to not be able to get patients into the unit because of denial of care. And part of the problem was these patients didn't get appropriate therapy, and they got hooked on opioids. They got hooked on drugs that contain butalbital. And so we had a harder time getting these patients to get successful therapy because of what had been done in the past. So it's a very large number. And I'm talking about the patients with frequent episodic and chronic migraine. I'm not talking about the patient with 1 or 2 headaches a month or 1 or 2 headaches a year. And my son, for 4 years of his life, was burdened with headache. And luckily, he grew out of them. So I've known, a personal story, too. Okay,
Thank you very much. So next, I'd like for Lynn Kaufman, Ms. Lynn Kaufman, to join us.
Good morning. This is my first public appearance ever speaking about migraines. Here I go. I remember my first headache. I was 12 years old, and my family had just moved to California. Everyone said it was the smog. I had headaches all through high school and college. I got through with handfuls of Tylenol. I was a high achiever, UCLA undergrad, a master's from USC, and a law degree. I planned a career in politics, but years of migraines whittled away at my ambitions. Migraine disease is complicated. It messed with every area of my life: professional, social, physical, and emotional. I wasn't sick, but I wasn't well. I vacillated between feeling sorry for myself and feeling guilty. Every few years, I convinced myself I had a brain tumor. I think I had 5 or 6 CAT scans. For me, it wasn't just a pain in my head. My whole body was affected. I had flu-like symptoms. My jaw hurt. My nose felt frozen. I was dizzy, nauseous, and had balance issues. My head felt like a cement block. My vision was blurry and my hearing was off. Certain sounds actually hurt my ears. Strong smells like perfume or ethnic food made me gag. Imagine how many times I changed seats in class or on a plane. My husband always said that I was just born on the wrong planet. Keep in mind that a day on migraine meds for me was not the same as a day without a migraine. The headache never really went away. About 2 hours after taking the meds, I couldn't keep my head up. I fell asleep at my desk more than once. I spent the rest of the day counting the hours until I could go to sleep. In my late 30s, I decided to take on the headaches. I saw my first neurologist and was identified as a migrainer. My search for a cure began. Every practitioner had a different theory. I spent years and thousands of dollars. I endured painful, poisonous head and neck Botox injections. He has left. Rented a costly oxygen tank, suffered multiple trigger point injections, wore a mouth guard, and had at least 2 sleep studies. I saw Chinese acupuncturists and chiropractors. I cut gluten, alcohol, cheese, artificial sweeteners, and soy sauce from my diet. I spent a fortune at a pain clinic here in Los Angeles and was told that I needed a breast reduction. So I did. For a few years, I convinced myself it was all sinus problems. I checked out different climates and considered moving my family to the desert or near the ocean. I was sad and frustrated. Eventually, it became clear that there was no cure for migraines. I never felt like the neurologists really got it. I realized that I was their least sick patient. They treated Parkinson's and epilepsy. I had headaches. There was no hope until now. Every word of this is true. I felt this way for 50 years. I told my husband on a regular basis, it's upsetting, that if I was ever in a coma, that he should feed me Maxalt every few days because I would be lying there immobile with a migraine and no one would know. It was truly my greatest fear. Several years ago, a doctor friend referred me to a migraine specialist in Santa Monica. I sat in his office and cried and told him that he was my last hope. We discussed every possible remedy, and lo and behold, I had tried them all. I remember that day well. It was my 8th or 9th day of a continuous migraine. He asked me to participate in a CGRP clinical trial. I will always be grateful for that life-changing invitation. I felt better immediately. I went from 14 migraine days a month to 3 or 4. Eventually, I was migraine-free. I still don't believe it. Since my last injection in mid-November, I have had 4 single-day migraines and taken prescription medications twice since November. No more medication, I'm off. Unfortunately, many of the other symptoms have not disappeared. I am still overly sensitive to sounds and smells, and I often have the neck and shoulder pain that generally accompanied a migraine. While on the CGRP inhibitor, I felt terrific. 90% of my symptoms disappeared. I never remember feeling better. I recently returned from a 2-week trip through Italy with my family. Miraculously, I got off the plane after a 14-hour flight, headache-free. Sleep schedules were off, no migraine. I ate bread and pasta, and I drink wine. I had 1 bad headache. Almost done. It's very difficult to explain the absence of pain. Imagine having the flu, the kind where your ears and your teeth hurt, and then you get better. That's what it's like to live a migraine-free life, Katie. I wake up in the morning without fear that my day will be ruined by a constant headache. I work under all kinds of lighting. I travel, and I don't worry about my sleep schedule. I eat and I drink everything, and I don't count the hours until I go to sleep. I no longer envy my friends who wake up in the morning pain-free. This new class of pharmaceuticals gave me my life back. I am incredibly grateful. Thank you.
I think you've left us all speechless. Thank you very much. And let's see. I'd like to invite Ms. Shirley Kessel for Miles for Migraine.
Good morning. Many generations of my maternal relatives have lived with the emotional and physical burden migraine causes. But what about the financial burden? My family has been deeply affected by this facet of migraine as well, and that is the focus of my testimony. My earliest memory of migraine disease was when I was 5 years old and standing by my mother's bedside. She was in the middle of a migraine attack which caused her to vomit so profusely that she could not keep the meds down in her stomach the doctor prescribed for pain. She was so weak from vomiting that she could not speak. I was asking her for something to eat, but she was unable to get up and take care of me and my 3-year-old sister. Luckily, I knew at 5 how to phone my father at work, but because he was unable to leave work, he immediately called the babysitter and had her sent over to care for my sister and me. There are 2 financial pieces to this story. One is that my mother constantly needed to rely on outside help during her attacks, and 2, she was unable to work outside the home because of the unpredictable nature of migraine disease. My mother had worked in the medical field until migraine forced her to quit her job. My father, who was a CPA and the stellar picture of health, was able to take on an additional job as an assistant university professor to supplement the family income. My mother rarely went to the ER since we would be responsible for 20% of the medical charges. Instead, my dad would drive my mom to a family physician who would give her injectable medication to lessen the pain and vomiting. When I turned 16, the same doctor instructed me on how to give my mother the injections. This activity always frightened me, but I did it anyway because I felt I had no choice. My mother's physical and emotional suffering not only affected her, but because of my father's outbursts from the frustration he endured, it disrupted the norm of what a family should be and robbed our spirits of contented memories. My father resented my mother's migraine and the loss of the extra income. This financial burden cost my family hundreds of thousands of dollars in lost income. The financial burden of migraine has further affected me, my own kids, and husband in my own now family. At age 24, I was working full-time, was enrolled in a part-time master's degree program in business administration. I was 4 courses into my degree when chronic migraine struck me and forced me to leave my education behind. The cost? Priceless. I have 3 daughters, 2 of which have inherited migraine disease, and 1 is standing in the back, and have cost my family more money than I thought possible. When my middle daughter, Julia, was 13, she was stricken with migraine and missed many days of school. The cost of hiring a private tutor was necessary to help her with her studies. 8 years later, my younger daughter, Sydney, was diagnosed with chronic migraine at age 16 and had to leave high school in the middle of 11th grade. That year, she left behind $15,000 of private school tuition. On top of that, we spent thousands of dollars to hire private tutors to help with the schoolwork because she was too ill to understand the academic assignments, since cognitive impairment is a disabling symptom of chronic migraine. When her status changed to homeschooler, we had to pay for her to finish her high school degree by taking courses now at a local college, which cost us well over $25,000. At age 18, Sydney was accepted into a 1-year CGRP trial, and the migraine disappeared. She not only finished her homeschool degree, but she enrolled into the George Washington University at the ripe age of 19. Her dream of becoming a lawyer was looking bright. Unfortunately, 1 week before school started, the CGRP trial ended. Her migraine returned and immediately forced her to part-time status. But we had already paid for full-time status, which meant no refunds. The cost? $18,000. What is the approximate cost of an additional 2 to 3 years of education, tuition, room and board to obtain an undergraduate degree? What is the cost of lost summer wages and intern experience due to migraine? What is the cost of hiring more tutors, paying for extra medical treatments in case they may help? What is a conservative estimate for all of this is well over $100,000 just for one of my children. In addition, what is the cost of losing a dream to go to law school because you are too sick to keep your head above water? The cost is priceless. I'm almost finished. My middle daughter, Julia, went from episodic to chronic migraine 1.5 years ago. She called me crying this past February when, ironically, I was advocating in D.C. for an event called Headache on the Hill. I was working with 120 other delegates to advocate for more migraine disease research funding. Crying, she said to me on the phone, "Mom, I can't do this anymore. I am so far behind in school, and it's making me feel worse." And so she left school the next day and left $15,000 of tuition on the table. She thought then going to school online for a degree in education might be the answer, but the migraine would not allow her to even do that. That cost us $10,000. The cost of not obtaining a master's degree is a financial setback for her and for us, her parents. My husband and I are now supporting our 27-year-old and 22-year-old young adults full-time because they are unable to work due to the disability of migraine. These two young women are intelligent, persevering young women who have always obtained AB grades. Yet, these two young women are not contributing to society because they cannot hold jobs, nor are they contributing to our tax system. What is the financial burden of this? Ironically, my oldest daughter, who does not have migraine, is now a physician. Her good health has allowed her to achieve the highest goal one could work for, becoming a productive member of society and support herself financially. The financial loss of migraine is impossible to measure when you take into account the effect it has had on 3 generations of women who have not only spent countless dollars on unproven alternative migraine treatments, but also have lost the opportunity for potential income to support themselves and their families. And I finally want to say I am on my 2nd week of the new CGRP inhibitor, and I have chronic migraine, and I have only had 1 migraine attack in the past week. I have gone from over 15 headache days a month to feeling a substantial difference. Thank you.
Questions? Thank you. Well, so I'd like to ask Dr. Gifford to come to the fore.
Thank you very much. My name is Brian Gifford. I am the Director of Research and Analytics at the Integrated Benefits Institute. We are a national nonprofit organization focused on health and productivity. I'm here to speak today about the employer's perspective on health and productivity and how this relates specifically to migraines. IBI, our business model generally, we use data analysis to demonstrate for employers the business value of a healthy, high-performing workforce. We know that employers have a stake in health issues for at least 2 reasons. First of all, they're payers, but even at a more fundamental level, they're running businesses. They need people to produce their products, provide their services, and if migraines or any other condition interferes with employees' ability to contribute to the business model, this is a loss point for the employer. In the most recent ICER report, and right here in this room, patients have described how migraine interferes with their ability to consistently attend work and to put in their best performance on the job. IBI's own research corroborates these stories as if they needed any corroboration, but we also estimate what this means for employers in economic terms. And we try to be as conservative as possible, but we find the cost to be substantial. And so, for example, we know from a recent analysis of AHRQ data that in addition to excess medical and pharmacy treatment costs of about $2,000 a year, employees with migraine had an average of 2.2 excess sick days per year at a cost of almost $600 in wages and benefits. We also know from analyses of employers' private disability insurance claims that while migraine is not a major driver of short-term disability leaves from work in the big picture, when these episodes occur, claimants are going to miss about an average of 38 work days at an economic value of all that lost work time is about $10,000. And of course, this probably undercounts, or certainly undercounts, the true economic implications of a disability leave from migraine. By the time that somebody is missing an average of 8 consecutive weeks of work due to migraine, they're probably at a high risk for exiting the labor force altogether. On the way, they may enter into the long-term disability system. We've seen in long-term disability claims, only about 1/3 of people can return to work after about 2 years. They may end up in the Social Security disability insurance system. But while they're on an employer's disability policy, it's going to cost about $37,000 in wage replacements per year of absence. And so all told, our estimates are that For a 1,000-person workforce, the lost work time associated with migraine is estimated to be about $23,000 in economic losses that are borne by employers. Now, none of these figures I'm citing should suggest that employees who suffer from migraine are less valuable than other workers in the normative sense, or that employers are going to be fated to endure these productivity losses. As we've heard, the ICER report notes reductions in migraine days associated with CGRP inhibitors and other therapies, and to me this suggests mechanisms for helping migraine patients manage their conditions in ways that can improve productivity. And this is indicated by a number of studies. A 2013 IBI analysis, we showed that employees with migraine and other, and other severe headaches were more likely to report sick day absences, and they had more difficulty concentrating at work, working carefully, producing work of good quality. But we also found that these difficulties were explained entirely by the frequency of their headaches. In other words, migraine patients' productivity was just as high as that of other workers when they were symptom-free. To me, these findings are a pretty strong suggestion that interventions that can help migraine sufferers avoid and mitigate attacks can improve their value to employers as well as their quality of life. IBI's work certainly is not the only research that supports this conclusion. Migraine prophylactic therapy has been found to decrease illness absences from work relative to placebo, and adherence with migraine treatment guidelines has also been associated with a more rapid return to functioning when people are experiencing headaches on the job. So just to wrap up, given the findings I've outlined here, employers should recognize that migraine in the workforce represents sizable productivity losses, but considering that migraine is both underdiagnosed and undertreated, the potential to reduce those losses is also sizable. My one word of caution here is that in IBI's experience of over 20 years of interacting with employers, migraine has not been an issue of great concern so far. Employers are more attuned to very costly treatments such as cancer and conditions that result in large disability losses like back pain. And my hope from today's conversation is that as employers consider how to incorporate promising new treatments into their health care benefit plans, that they take into account the business value of these therapies as well as the cost of these therapies. Thank you.
Are there any questions, comments? Thank you.
All right, so with that, we can break for a brief lunch.